Okay, hello everybody. It's 10 to 4 now, so we're just going to make a start on the last session, and I'd like to welcome Nick Smith, who's going to talk about understanding and measuring safety in older adult care homes. Are you ready, Nick?
I am, yes.
Oh, brilliant, perfect. We're all sitting here waiting. I've seen everybody sort of come back to life again after the break. It's a bit like that bit in The Lion, the Witch and the Wardrobe, where everybody who's in, all the people who've been turned into stone by the White Witch suddenly come back to life. And I've been watching everyone come back to life over the last few minutes. So we're ready to hear you, Nick. Thank you.
Okay, I'll just share my screen. So can you see that?
Yep.
Thanks, Joe. So I'm going to talk about understanding and measuring safety in older adult care homes. And I'm talking on behalf of a much larger team with myself, Karen Jones, Stacey Rand, Robin Darton and Alan Dargan from the University of Kent, Helen Hogan and Sarah Morgan from the London School of Hygiene and Tropical Medicine, and Bethan Page at the University of Oxford. So there's the obligatory disclaimer. So this project overall aims to explore how safety is conceptualised and measured in older adult care homes, and whether it's possible to use safety indicators from the healthcare sector in ongoing monitoring. And in particular, we looked at a framework called the Safety Measurement and Monitoring Framework, the SMMF, from Vincent and colleagues. And I'll go through that framework in a minute. And the work has had so far 3 phases. The first phase was 2 different activities: a scoping review of safety indicators and an analysis of safeguarding adult reviews. The second phase was interviews with strategic stakeholders, and the third phase was interviews with care home managers and staff. So I mentioned that we've been very much looking at how safety in older adult care homes and the indicators relate or map to healthcare frameworks, and this framework in particular, the Safety Measurement and Monitoring Framework, the SMMF. And this framework has 5 dimensions: harm, reliability, safety to operations, anticipation and preparedness, integration and learning. And each of those dimensions asks a question. So for example, harm asks, has patient care been safe in the past? Whereas reliability asks the question, are our clinical systems and processes reliable? Sensitivity to operations asks, is care safe today? The anticipation and preparedness dimension asks, will care be safe in the future? And finally, the integration and learning dimension asks, are we improving and responding and improving? So this is a framework we've come back to throughout our work. And so that first phase, the first activity in our first phase, was a scoping review. And it aimed to identify measures that could be used as indicators of safety for quality monitoring and improvement in older adult residential or nursing care homes. And our scoping review identified 45 studies focusing on safety in older adult care homes. And the indicators contained within these studies were mapped to the SMMF. And if you want to know further details about what we actually did, we have an article published in the BMJ Open. But to give you just a really quick summary of some of the things we found in that scoping review. So we found that there was a range of available safety measures used for quality monitoring and improvement in the care home domain. But what was really interesting is that they covered all the 5 dimensions of that SMF model. For example, we found the use of measurements of pressure ulcer, measurements of pain and falls, which fitted really nicely with the dimension of harm. And when we think about reliability, the dimension of reliability, we found medication-related measures that fitted really nicely with that dimension. And for every single dimension, all those 5 dimensions, we found indicators that fitted and mapped to it. But that wasn't to say there weren't gaps. So some of the gaps we found in the literature and in the indicators that were out there already in the published literature was very little on the user experience of safety, how residents themselves experience safety within older adult care homes. Very little on the psychological harm that could be related to a care home environment, and very little in terms of indicators around abuse and neglectful care. And a lot of these gaps seem to relate to challenges and feasibilities in terms of measurements in the older adult care home context. So if you think about the user experience of safety, that requires understanding the experience of people who live in older adult care homes. And we know that a large number of people who live in older adult care homes live with cognitive impairments such as dementia. And as researchers, there are lots of challenges in terms of creating methods that enable us to understand people's experience. I'm going to go on to the other activity in phase 1 now. So the other activity was an analysis of safeguarding adult reviews. And these are multi-agency reviews which seek to understand if relevant agencies and individuals involved in supporting someone and caring for someone could have acted differently and prevented harm or death from taking place. And we reviewed the content of these reviews to see how well those safety issues that they identified in older adult care mapped again to the SMF and its 5 dimensions. And we identified 18 safeguarding adult reviews authored between 2015 and 2018 relevant to older adult care homes. And we identified those through the Social Care Institute for Excellence Adult Safeguarding Library. And so just very quickly, some of the key things we found is once again, we found that all the dimensions of the SMF were relevant to social care, and at least in terms of the content of these reports. But that when looking at these dimensions, the context of older adult care needed to be considered. So for example, we felt that the balance between psychological and physical harm need to be considered more in depth. So a lot of the harm measures were on physical harm. A lot of the talking about a lot of the discussion in the reports was on physical harm, and less so around psychological harm. And we felt that in older adult care homes, where people often spend a lot longer in them, it's their homes, there was a greater potential for psychological impact. So if you think about not being treated with respect and dignity over a long period of time, or conflicts with another resident over a long period of time, are much more likely to become a psychological burden. The other really interesting thing we found while looking at the safeguarding adult reports was that if we thought about factors that influence how safe residents were, a number of them sat outside care homes. So while there were things about how care homes supported people, there was also factors sitting outside in other organisations, such as staffing issues in occupational therapy teams or staffing issues in community psychiatry teams that had a direct impact on the safety of care home residents. And one of the issues we thought about was how the SMMF can be applied to not just a single institution, but a group or a system. But when we're thinking about a care home, we may be thinking also about a local authority and health services and other voluntary services. The system becomes very fragmented. So measuring safety of the care home resident across that very fragmented system of support is filled with challenges. And so the second phase of our work was strategic stakeholder interviews. And this aimed to understand the views of strategic social care professionals on the measurement of safety for monitoring and improvement. And so we conducted 18 interviews, and we could break down those strategic stakeholders into 5 groups: providers and provider associations. And so the representative from providers were people who worked at a strategic level as opposed to directly managing and supporting care. CQC, local authorities, NHS Digital England and Improvement, and GPs. And we did a thematic analysis on those 18 interviews. And what we found was that when they talked about safety and safety data, there was an awful lot of safety and safety data being collected. And I'll just give you one example of a single provider. And it's basically a long list of some of the things that they collect that they felt was relevant to safety. So they collected pressure care, weight loss, infection, mental capacity assessments, how many people are on antipsychotic drugs, if so, how many drugs are they on, deaths, cause of deaths, care plans, medication errors, medication reviews, health reviews, care reviews, bed rail use, services that have been attending A&E, how often dentists go in, how often chiroptists go in, compliments, complaints, comments, resident involvement, resident meetings, relative meetings, how many visits outside the home has, and then all of that analysed against a resident wellbeing score. So that was just one care home provider, and a huge long list. So a lot of different things being collected, and also a really very broad range of what was defined as safety data by our stakeholders. And we also had stakeholders talking about staffing data, about staff training. Lots of the data they talked about was quantitative, but at times they did mention more qualitative data and also soft intelligence, as they termed it. So while there was a lot of data being collected, we moved on to talk about what they did with this data. And there were some really nice examples of data being used by these stakeholders and by their organisations for learning. And two really nice examples. One was a thematic review carried out by CQC that they shared on their website and shared nationally. So they collected data, analysed it and shared it. And another one was a provider who mapped fall patterns in order to understand the pattern of falls and how they could change their practice to support residents better not to fall. But, and I think that last one, so this great work by this care provider looking at falls, but it only stayed within that care organisation, and they didn't share it beyond with other care homes, the local authority or anyone else. So it stayed within that organisation, and that was something that came up again and again in our conversations, was people talking about, we collect data, but we only look at it internally, and that could be local authorities talking about local data for local people. But also a few stakeholders talked about their concern that when they did collect data, it was used for blaming. And a handful of different stakeholders also talked about how data that they or their organisation collected not ever being used. Some have been quite frustrated. They've been asked to collect some data on something and they'd handed it on to someone and they knew it had never been used. So there was concerns about data being collected and not being used. And one person who did a lot of work supporting care homes to use data felt that a lot of care home organisations didn't really have the skills to use data well. And so thinking about phase 3, and this is the phase we're in right now. And so we've moved on to thinking about speaking to care home managers and care home staff. And the aim is to explore ways in which the concept of safety is interpreted within the home, how they support safety, and how safety data is collected and used in older adult care homes. And we started this work just before sort of last autumn. In the end, it's ended up being delayed due to COVID. It's been very challenging to recruit care home staff and care home managers over the COVID period. And the plan was to interview up to 20 care home managers and 20 care home care workers. And currently, 3 managers and 2 care workers have participated. So we haven't got clear findings from that. One of the things that started to come out is that it's not huge, but the care managers and staff seem to be much more comfortable talking about what safety is and how they support it, as opposed to talking about measuring data and collecting safety data. This field work is due to run till July 2022. So another few months, and we've been using a range of methods to contact people using the CRN network, Enrich, and various other networks in order to recruit care home staff and care home managers. And so if we think about what our work has shown so far, well, I think phase one suggested that the health-derived model, particularly the SMMF, was relevant to older adult care home settings, but the different context might mean that those dimensions need to be defined or operationalized in a different way. I think another thing is how does that fit with the views and experience of strategic stakeholders? And so far we've looked at what they collect. We haven't done much mapping, but if you look at the real broad range of different data they collect, you can quite clearly see how it starts to fit with a number of those different domains. Of course, the next thing to do is to start seeing how well care home managers and staff and their views of safety fit with that framework. And what we'd hope to go on to do is to speak to residents and their family members about their experience and their views of safety, and see how that fits with this model, these 5 dimensions of harm, reliability, sensitivity to operations, anticipation, preparedness, and integration and learning. And so we're looking at the possibility, and I think at the moment it's quite difficult to sort of plan talking to residents and their families. We're hoping that perhaps later in the year we can start putting together that 4th phase of work. And so thank you very much for listening, and any questions?
That's perfect, Nick. Perfect timing and really interesting presentation. So I'm going to try and hope that I can see if anybody puts their hands up to ask Nick a question. Then if you can just raise your hand electronically. See if I can see anybody. Well, Nick, you've stunned everybody.
That's good.
I think that's right. So I suppose I'll just make a comment myself just to start the discussion then. I was really interested in the fact that you showed how the diversity of the way that term safety is used, because it's sort of, we think we know what we mean by safety, don't we? And then actually when you unpack it, it's more complex.
Yes, yeah, and there were different ways to think about it. There's lots of different dimensions, which if you start thinking about dimensions of safety, the idea that you might have one indicator of safety becomes problematic. But I think it's also really interesting how much data and how broad the strategic stakeholders view safety. So I read that big long list out. If I think about some of the other people involved in interviews, they talked a lot about staffing data. How many staff do we have, and how well are they trained or qualified? So it becomes even wider, the way they view or view data as related to safety.
Yeah, no, that's fantastic. So there's a question here from Ray, and then following that, Jason's got a question for you. So Ray, over to you.
Thank you very much, Jo. Thank you. Very interesting work. The impression I'm forming about care homes is that they have close to zero capacity to do anything relating to data collection, and even less sort of data sort of interpretation and, you know, kind of making sense of it. Do you have any reason to feel that that impression is wrong, and that there is capacity there to do the basics of monitoring of well-being, safety, etc., or am I right, and there's very limited capacity and we need to think about solutions for that?
I think My answer is yes with a but. So yes, I think there is, and particularly in the current context, very limited capacity to ask people to do anything extra. But I think reflecting on particularly the strategic stakeholder interviews, and I'd be interested to see how this is reflected when we've done a few more care home manager and care worker interviews, is that there's actually already an awful lot of data collected. It may not be consistent, it's clearly not consistent across different organisations, but there was clearly organised care home organisations and local authorities and collecting an awful lot of data already. I mean, you know, that big long list was just one care providers off the top of the head list. So that's my but. So the next part is then how do they use it better? And there seems to be, you know, questions about it not being used very well, and that could be where it is used well, it tends to stay within, I suppose, with care home providers almost entirely being in the private sector. They're not keen to share their data with another provider who may be a competitor, and you know, there are other reasons. So I think there's an issue about what can we do with what we already have, and I think, you know, when you were talking earlier about your work on a core set of things being collected, there could be a question about not collecting more, collecting differently, so that there's more read across. So I'm not sure it's necessarily about care homes doing more. It might be about using it better and perhaps more thinking about what is the best use of their time if they're collecting anyway, I think is my kind of roundabout answer there.
That's really helpful, Nick. Jason.
A question and an observation, if you like. Observation first, having sat on sort of domestic homicide reviews and serious untoward incident case reviews and all of those sorts of things in the past, there's often a realm, you know, tons and tons of interesting qualitative and quantitative data collected. A massive, great big report gets compiled, and then how that ever gets fed back to those who work on the front line is almost non-existent. So, you know, the real question is squaring that circle. So interesting to sort of relate that to the findings that you had there. That's my observations aside. The question, I guess, is one about the sort of punitive use of safety data being collected. And, you know, the sort of correlation for me would be as a junior doctor getting told, if you don't come now, I'll write an incident form on you, or, you know, we'll write one of those safety forms on you. And so, well, no, you're not writing it on me. It's a fact that I can't come to you now because I'm attending something else and it's no longer safe. So that's safety data. But it could often be used in quite a and was perceived by the staff sometimes that it would be used in a punitive manner, and I was wondering how much that sort of had come across in the qualitative and quantitative stuff in the care home sector, and see if it's similar to the health sector in that respect.
So what we have, where that comes from, is just a couple of strategic stakeholders mentioning that they felt it was punitive. They didn't give great examples, and I think it's something we do want to explore more with care home managers and care staff themselves, about how they feel safety data is being used and how they feel about reporting things. And I think also, I think that point also goes back to your first observation about, you know, safety data not reaching the front line. And I think that's one of the things in this current stage we're trying to explore is actually what data do you use? What do you find useful? What would be useful? And do you use anything? Getting a sense of if there is anything that in this reams of stuff that might be being collected and might be out there that is actually ever being used. And if not, why not? So those questions you raise are things that we're very much exploring in this current stage of work. So hopefully we'll have at some point more to say on that.
And Jonathan's got a question for you now, Nick.
I'm afraid I can't hear you.
Sorry.
Yeah, you're still on mute.
Just a couple of points on things that already happened and might be useful. I put in the chat the notification forms that are required to be submitted to the CQC. So they're receiving quite a lot of information on deaths, serious injuries, abuse notifications and other things, which are obviously rather sensitive, and it wouldn't necessarily be wise to publish identifiable data, but publishing local authority level data or averages or things like that could still be helpful. So the CQC hold quite a lot of information. My other point was just on, it is technically possible to identify care home residents in HES, in hospital episode statistics, and processes for making that more routine would clearly be helpful, I think.
Yeah, I think just, yeah, so I think we did include CQC in our strategic stakeholder reviews, and they were the ones that provide, they talked about their notifications as being data collected, and they were the ones that provided us perhaps with the best example of data they collected through various methods being shared much wider. So they talked about creating a thematic review. Off the top of my head, I can't remember what that review was on now, that they published on their website. So they collected data, analysed it and shared it publicly. So they were probably one of the best examples of safety data being collected and shared widely.
Something just to add to that is if systems can be set up that sort of maintain themselves, websites that are, or APIs that are updated automatically, that would be really, really helpful as well.
Okay, Jose Luis has got a question for you now, Nick.
Thank you very much. I agree with John that having local authority level data is useful and might be more practical from the point of view of anonymizing the data. But a lot of the sort of the natural unit of analysis is going to be the provider, no? Because that's where there's going to be a lot of variability in practice. But in terms of using statistical techniques there to, if we're looking at notifications, for example, that's something that is going to hopefully happen very rarely. And therefore, in terms of the reliability of the data, the sort of having enough variability to sort of have, because there's the judgment, is this a one-off? Is this something that is, systematic? And so I was wondering whether there, whether there's work ongoing to try to link this to other things which might be more frequent. For example, utilization of certain health services, emergency services, or ambulance, utilization, because those might happen more frequently, might give you stronger data, if you see what I mean, purely from numbers point of view.
Not that I know off the top of my head. I think what we had was we found that there's a range of different stuff. There's stuff that's quite rare. So if you think about the serious incidents, luckily they're fairly rare. But if you go to the other end of almost all stakeholders talk about collecting falls data, that unfortunately is quite common. So I think there's a whole range of data that's collected a lot to data that's less likely to be collected because it doesn't occur so often.
That's really interesting. I wanted to, thinking about data that's been collected, we did a study looking at handovers in care homes. And one of the things that was really striking was how standard it was for the staff to complete intake and outtake fluid charts for all of the residents, even if they didn't have any problems eating or drinking. And it felt like that was sort of data overload, really. Mm-hmm. It was, they were worried about safety, but it seemed a bit extreme.
And I think if I'm trying to remember now, but I think wasn't there also stuff around data not being passed on from one shift to another at handovers? I think that's one of the things that came up. So I think that stuff is included in our scoping review.
Yeah, no, that's really interesting. We've just got about a minute left before the final presentation. If anybody's got a very quick question to ask Nick. Okay, so if no one's got anything that they want to add, just to thank you very much for that really interesting presentation, Nick.